Hello, my name is Chase Driver, and this is my midterm prototype presentation for PulsePoint, Smart Wearables for Overdose Intervention. This project is part of the Entrepreneurial New Venture Creation course at the University of North Georgia. At the start of the semester, I began with a broad lens, public health in North Georgia. Through research, stakeholder outreach, and innovation mapping, I began identifying which public health issues were the most urgent, most underaddressed, and most suitable for innovation. It quickly became clear that the rise in drug overdose deaths, specifically opioid-related fatalities, was not only the most lethal public health trend in the region, but also one that has been growing rapidly and showing no signs of slowing down. Between 2019 and 2021, opioid-related deaths in Georgia increased by more than 200%. In North Georgia specifically, counties like Lumpkin and Fannin now have overdose fatality rates above 35 per 100,000 residents. That's more than triple what's considered a high-risk threshold. Fentanyl, a synthetic opioid up to 100 times more potent than morphine, is now involved in 3 out of 4 overdose deaths. These are not isolated incidents. They are part of a growing systemic failure. This month, the DEA seized over 214 pounds of fentanyl from a massive pill pressing lab in suburban Atlanta. That's enough to kill 48 million people. The bust occurred just 2 miles from an elementary school. These headlines aren't just shocking. They're deeply personal to the region I'm studying. And for rural communities like those in North Georgia, the problem is magnified by isolation. Most overdose victims die alone, without anyone nearby to call for help or administer naloxone. My initial exploration of this issue was broad. I wanted to understand what was truly causing overdose deaths to rise in rural North Georgia. Using the Think Bigger framework, I broke the broader public health challenge into smaller, interrelated components. Through this lens, I identified 3 key contributing factors. First, economic instability and unemployment. Historically, these communities relied on industries like textiles, timber, and mining, many of which have declined, leaving economic despair. Second, a severe lack of treatment infrastructure in rural areas. Many counties have no rehab centers, detox facilities, or consistent telehealth access. Thirdly, the escalating opioid crisis, with fentanyl rapidly replacing other substances in the local drug supply, often unknowingly. Each of these factors could be the basis for its own innovation project. But for this venture, I've made a deliberate decision. I am focusing specifically on solving for the opioid crisis itself. Why? Because fentanyl overdoses are the leading cause of drug-related death in this region, because they are preventable, and because technology, particularly IoT, offers a way to intervene at the most dangerous moment, the overdose event itself. This narrowed focus shaped every step of my innovation process moving forward, from my stakeholder interviews to my system maps, to the tools and models I selected to explore solutions. Everything flows from that core focus. How can we reduce preventable deaths from fentanyl overdoses in rural North Georgia? My research strategy was dual-pronged. Secondary research across 20-plus academic, government, and nonprofit sources, and primary research via stakeholder outreach in North Georgia. 4 global case studies have deeply influenced my thinking. 1, Baltimore, Maryland, naloxone kiosks. Baltimore installed naloxone dispensing kiosks in public areas based on real-time overdose heat maps. Each unit costs $2,500 to install and $500 per year to maintain. These kiosks provide 24/7 access to life-saving medication, dramatically reducing deaths where traditional distribution channels fall short. 2, Columbus, Ohio, predictive EMS analytics. The Smart Columbus initiative uses AI-driven dashboards to predict overdose clusters and improve EMS readiness. Within 18 months, opioid-related EMS calls dropped by 26%. The initiative demonstrates the power of real-time analytics in resource-strapped environments. 3, Amsterdam, wearable biosensors. Amsterdam's public health pilot equipped at-risk homeless individuals with biosensors to track heart rate variability and relapse indicators. The program was low cost, around $300 per person per year, and emphasize passive support, technology that listens instead of asking for input. 4, British Columbia, Brave app. The Brave app allows users to initiate a check-in timer while using Alone. If they become unresponsive, an alert is sent to a volunteer or EMS. Though mobile-based and not wearable, it's a strong model for combining technology with community trust and low-barrier safety. These studies show that targeted, tech-enabled intervention, especially when grounded in trust and user dignity, can be life-saving. They've informed not just my understanding of what's possible, but of what's missing in rural Georgia. My environmental scan, guided by a pestle analysis, helped me understand external forces shaping this issue. Political. While state-level support for harm reduction exists, rural counties lack the infrastructure to implement it. Economic. 1 in 5 households in Appalachian Georgia lives below the poverty line. Many residents have lost employer-based insurance and access to care. Social. Stigma remains a powerful deterrent. Many users avoid treatment out of shame or fear of judgment. Technological. Over 30% of households lack broadband access, limiting the effectiveness of telehealth and smart interventions. Environmental. Rugged terrain slows EMS response. Legal. Naloxone is legal, but access is uneven, especially in EMS fleets with tight budgets. In parallel, I developed a stakeholder map. I identified voices ranging from EMS responders to families who have lost loved ones to overdose. I started collecting 75-plus survey responses and conducting 10-plus interviews. Many recurring themes emerge: stigma, fear, helplessness, and a desire for dignity and safety, especially when using Alone.
I've applied several innovation tools to frame and explore the opportunity. The business model canvas helped me visualize a future delivery model. Who would benefit? Who would fund it? What partnerships would be needed? I created a series of how might we questions to inspire divergent thinking. How might we detect overdoses in real time without user input? How might we alert responders before it's too late? How might we deliver care in high-risk areas without new brick-and-mortar centers? These questions move me into the generate possibilities phase while avoiding the trap of premature solutioning. I also began incorporating principles from open innovation and democratizing innovation, treating users not as passive recipients, but as co-creators and validators. Throughout this project, I've used a range of innovation strategies, not just as theory, but as tools to guide real decisions, clarify direction, and make sense of a deeply complex crisis. Let me briefly walk you through each method and why it mattered. Think Bigger framework. Sheena Iyengar. This framework helped me avoid getting overwhelmed by the scale of drug-related deaths in North Georgia. Instead of trying to solve every part of the problem at once, opioid crisis, unemployment, rural infrastructure, I used Think Bigger to identify the specific moment where the risk was greatest and innovation was possible, the moment of overdose, particularly when the person is alone. That focus allowed me to define a solvable opportunity inside a seemingly unsolvable problem. Open innovation. Henry Chesbrough. Open innovation helped me step outside traditional silos. Rather than relying solely on academic sources or government data, I looked at case studies from Canada, the Netherlands, Baltimore, and Columbus. Places using wearables, kiosks, or data dashboards to reduce overdoses. This comparative lens opened new possibilities and allowed me to pull in ideas from systems that have already been tested, saving time, resources, and helping avoid past mistakes. It also encouraged me to seek collaborators outside my discipline, like public health officials and technologists, who are already working on similar problems. Democratizing innovation. Eric von Hippel. This approach reminded me that the best insights often come from the people closest to the problem. For me, that meant centering individuals in recovery, EMS workers, and families affected by overdose. I designed my surveys and interviews with one goal: to let the community help shape the project. Instead of imposing a solution, I listened. What emerged were key design principles. The solution must be discreet, must not require user interaction during an overdose, and must be trusted. These insights will directly guide any prototype I pursue.
Wisdom of the Crowds, James Surowiecki. This model emphasizes that large groups of informed people, especially diverse ones, can often predict outcomes better than experts. This directly informed my plan to collect 75 plus community survey responses and 10 plus stakeholder interviews. The goal wasn't just validation, it was collective sense making. Through this crowdsourced feedback, I was able to identify consistent pain points, prioritize user needs, and refine my how might we questions to reflect the lived experience of real people in rural North Georgia. Together, these models form the foundation for every strategic decision I've made so far. They help me frame the right problem, engage the right people, gather the right insights, and begin imagining the right kind of solution, not just one that's technically feasible, but one that's meaningful, equitable, and scalable. In terms of opportunity landscape, the biggest insight so far is that there is a gap between risk and response. National agencies are seizing record amounts of fentanyl, like the 214-pound bust in Atlanta last week. But local communities still lack the tools to intervene when it counts. Existing solutions, like naloxone or peer support, are only effective if someone is there. In rural North Georgia, people are often alone. That's the gap I'm investigating, an opportunity for IoT-powered innovation to meet people where they are. I'm not offering a solution today, but I'm starting to see a clear possibility space. What if we had a discrete, wearable device that could passively monitor vitals, like oxygen saturation or movement, and send an alert to responders if a life-threatening pattern is detected? This isn't a pitch. It's an idea in formation, grounded in my interviews, surveys, and the models I've applied. As I move forward, this early vision will evolve, especially through co-design with EMS, recovery advocates, and individuals who use drugs. For now, it represents a convergence of innovation theory, user need, and urgent opportunity. My roadmap for the next phase includes completing stakeholder interviews and community surveys, collaborating with local EMS to validate pilot feasibility, prototyping a basic wearable monitoring concept, conducting a small test in a recovery community or mobile home park, refining the business model canvas with real-world feedback, exploring legal, ethical, and privacy frameworks, especially around biometric data. This is about listening, testing, and iterating, with the people who are most impacted leading the way. I began this project wanting to address a public health crisis in North Georgia. Through research and innovation tools, I narrowed in on one that is especially urgent, especially lethal, and especially preventable: the opioid overdose epidemic, driven largely by fentanyl. This crisis affects thousands of families in our region. My goal is to use innovation not to treat addiction, but to keep people alive long enough to recover. PulsePoint is still in the exploration phase, but the direction is now clear, and the urgency couldn't be greater. Thank you for your time, and I look forward to sharing what I learn next.